Thank you for taking the time to join us this evening. We have Dr. Angel Johnson here to present on all things bladder and bowel incontinence. And she's going to discuss treatment options available for you, the disease state, and everything that you'll need to know relating to incontinence. So without any further hesitation, Dr. Johnson, the floor is yours, and thank you for taking the time to do this.
Absolutely. Hello, everyone. Good evening on this Monday, and welcome to a community health talk on everything incontinence. So I'm going to talk about bladder and bowel function and bladder and bowel dysfunction. We're going to talk a bit about the conditions, how common these conditions are, and some treatment options, just so that you don't have to live this way. So let's get started. So first off, just a little legalese. We're going to start off with just some important safety information. There's a lot on your screen. We're not going to read through it, but it's just some disclaimers. Now let's really get started. So now bladder and bowel symptoms or bladder bowel dysfunction is exceedingly common, and many individuals find themselves with certain justifications, certain phrases that we use in our everyday diction that really show evidence of how common bladder and bowel dysfunction is or are, and ways that we kind of adapt our life to deal with this. So a common one on your left is, I drink less before I go on a trip. I don't know, I can't count the amount of patients have told me that if I'm in a car, going on a long car trip, going on a plane, that I just don't drink anything. Or even if I have to leave my house, that they rather dehydrate themselves than have an embarrassing accident. The individual in the middle said, I missed the best part of the show. So, you know, it's that moment where she couldn't wait any longer. She had that bothersome urinary urgency frequency and had to get up. And so missed the climax, or missed, you know, again, that critical part of the show. And the last person is, you know, I need a bathroom nearby. I'm never comfortable unless I know exactly where the bathrooms are. So when I first started in practice a while ago now, I had a patient show me an app that shows her, no matter where she is, where the closest bathroom is. And that alone lets me know you have overactive bladder and we need to do something about it. So big thing is, very common condition, but you're not alone. Although it's very isolating to have bladder and bowel leakage and incontinence, you're not alone, and it's a very, very common condition. So overactive bladder is common in the fact that it impacts an estimated 50 million people in the United States, both men and women, and approximately 20 million people suffer from fecal incontinence. So fecal leakage or accidental bowel leakage is as common as asthma, yet no one speaks about it. And the most distressing fact is that only half of those with severe symptoms ever seek treatment. So we first start with understanding the condition. What is happening, what's going on, and why? And so there's kind of three main presentations. The first one is what's called overactive bladder, or OAB, and it's the sudden urge to urinate when you're unable to control it. So that's I gotta go right now, get out of my way because I have to go to the bathroom. Next is called urinary retention, and that's the opposite. That's when you have difficulty urinating. You feel like you never completely empty, and that's a very common condition. And another symptom of that, or what patients describe, is you just feel wet all the time, because you can have retention where you're never emptying, and so then you just overflow. And so once the bladder is full, it just slowly will leak here and there. And we call that overflow incontinence. And that's as if you stick a cup under the faucet and it just runs over. And lastly, fecal incontinence. Another name for that is accidental bowel leakage. And that's the involuntary loss of stool, whether that's liquid or solid. So let's back up again and talk about normal bladder function. You know, what does your bladder do? So initially, the bladder just should passively fill throughout the day. And the rate of filling really depends on your fluid intake, you know, how well hydrated you are. There's nerves, which are like wiring, that then send a signal to the brain to let you know when it's time to urinate. And that brain will recognize those signals and cause the bladder to contract. And so it will contract down in this circumferential way, and then cause the urethra, which is, if you can see here, is this kind of funnel portion here, to relax and then open. So it's kind of a squeeze from the top and relaxation from the bottom, so urine will be expelled. And this is critical, because I have a lot of patients who feel, you know, what do you mean my bladder is overactive? I feel like it's not functioning. And a normal bladder, or a bladder in general, wants to empty. It always wants to empty. It actually takes neurologic control to put brake on the bladder to allow it to just passively fill like a balloon. And so if there's ever a problem with the nerves or with the bladder muscle itself, that's where you end up with leakage or urgency because the bladder wants to empty. So now what is overactive bladder? So overactive bladder, or OAB, is that frequent and urgent need to empty the bladder. It also can be associated with urgency urinary incontinence, which is that unintentional urine loss. It's categorized by 4 main symptoms, one being urinary frequency. So that's usually urinating greater than 8 times within a 24-hour period. Urgency is that sudden urge to go to the bathroom that you can't suppress. And then urgent incontinence is leakage associated with that urgency. Now, nocturia is getting up at night more than 2 times with the urge to urinate. So now what happens with overactive bladder? So we initially started with a discussion of normal bladder function. Now we're moving on to abnormal function. So overactive bladder symptoms occur because of abnormal communication between the brain and the bladder. So again, it's that wiring. So I like to kind of paint the story of a light switch and a light bulb, right? If the light bulb is out, the first thing you do is you change the bulb. But if the light is still out, then you need to back up and figure out, is it the light switch? Is it the wiring? And that's what can happen with the bladder, is that first, when we treat overactive bladder, we function or we focus on the muscle. And if that's not working, then we take a step back and we focus on the nerves that send the signals to the bladder. And so now when you're having this abnormal communication between the brain and the bladder, that can lead to that urgent need to urinate and that unwanted bladder contraction, or what I commonly call a bladder spasm. And that then can lead you to rush to the restroom. And that can even be associated with urine leakage in the process. And so that's, again, that I gotta go right now. And one of my patients, she describes it as the PP-itis. So now we're moving on to another type of incontinence called stress urinary incontinence. And that's urine leakage with activity. It can be caused by coughing, sneezing, and any movement that puts more pressure on the bladder or on that opening called the urethra. And now we talked about the overactive bladder and the stress incontinence. And commonly there's a lot of overlap, and that's what this Venn diagram shows. And that overlap between stress incontinence and overactive bladder is called mixed incontinence. And most women have a mixture of both. Stress incontinence is very commonly developed after childbirth. And then later on in life, urgency usually presents, commonly around menopause, but it can be thereafter. And like I said, many people have mixtures of both. So now let's talk about bowel function. So you know a bit about bladder, what about bowels? So bowels function very similarly. And so the rectum will fill. It has stretch receptors within the rectum that then show the nervous system that it's distended and full. They send the signals to your brain, and that gives you that urgency to defecate. And then in order for you to empty, it's coordinated signals that relax the pelvic floor muscles, contract the bowels to expel the stool. So then again, what goes wrong? And that's called fecal leakage or accidental bowel leakage. And that could be loss of stool that's liquid, solid, mucus, even the brown staining. If you notice a persistent brown staining on your underwear, that's all part of fecal incontinence. And it tends to have 3 symptoms or 3 categories, one being what's called fecal urgency. And that's that sudden urge to pass stool where you have to pull over on the side of the road, where you're running to the restroom and you're afraid that you may just not make it in time. Urgency fecal incontinence, so fecal leakage after or following that sense of urge, and then passive leakage. And that's when you just notice stool on the underwear, whether it's liquid or solid, and you couldn't tell when it actually occurred. And that's more passive. And so with both these conditions, they significantly impact your quality of life. Actually, bladder and bowel incontinence is the #1 reason why adults lose their freedom. It's actually the #1 reason why elderly individuals are institutionalized and go into nursing homes, because it severely impacts their quality of life. It's debilitating, and it really can weigh on even their caretakers. And it really hits you on all the fronts, whether it's physical, you're going to limit your participation in certain activities. For many of my younger patients, they're not going to go to that exercise class because if they do a jumping jack, they'll pee their pants. Social, you may reduce your social interactions. You may not travel. You may not want to go on a plane. Psychological, you start feeling guilty and depressed. It can be isolating. It can cause anxiety because of just the stigma and the fear behind these conditions. Sexual side effects. People will avoid sexual contact. Some women leak urine with activity, and so they avoid it. Occupational. You don't want to be the person always found in the bathroom, always getting up from their desk. And so that can lead to unwanted absences from work, decreased productivity. And then domestic, wearing pads or diapers, requiring special bedding and pads and things like that. And then just having that extra set of clothes and that backup clothing. All of those things are, like a set of bricks that weigh you down when you're suffering from these conditions. So there's a lot of misnomers, there's a lot of misconceptions. And part of what I do in my job every day is to demystify these. The amount of time I hear people say, well, I'm just getting older. Of course, I had a child. So of course I leak urine with cough, left, sneeze. And I tell them, no, as long as you're potty trained, ever since you were 3 years old, it is never normal to have accidents of urine. It's never normal to lose control of your bowel. It's not part of being a woman. It's not an issue with your prostate. For men, their prostates get enlarged. And it's not caused by something you did. This is not your fault. It's a condition that developed, the bladder's irritated or the bowels are irritated, and they present in this way. So good news, there's treatments. And there's treatments that are minimally invasive, don't require a lot of intervention, that are effective. And they will help you regain control of your bladder and bowels. So now we're going to kind of transition our talk into treatment options. So about the conditions, about normal bladder function, normal bowel function, and then abnormal function. And now this is how I, as a physician and other doctors in the area, can help treat your condition. So first of all, I always like to initiate what's called a patient care pathway. So as a physician, we always start with least invasive, and then we kind of go up the ladder according to what we need. And so when you see a physician or you come into my office and you see me, the first thing we'll do is have a consultation. We'll discuss your symptoms. Some people will come in with a diary of saying, hey, yesterday I got up 5 times. Yesterday I used 5 Depends. Yesterday I only drank 8 ounces of water because I was out and about with my grandchildren. I didn't want to have an accident. And so really the first visit, I do a lot of listening and not a lot of talking, which can be hard because I'm a talker, but I have to get all of the information from you so I know how best to tailor treatment to meet your goals and to be successful in that way. And so then depending on your goals, depending on the symptom severity, I'll come up with a treatment plan. I initially start with things like behavioral modification, talking about bladder irritants, but from some of my more severe cases, I will give you a medicine from day one if it's significantly impacting your quality of life. Then we'll have a follow-up. I typically see my patients back in 4 weeks. We'll follow up to see, did cutting out caffeine, did cutting out seltzer help you? Did that medicine help you? Did you have any side effects? And I'm able to kind of manage and continuing to tailor that treatment to fit you. Now, for the majority of patients, medicines are not enough. They only work about 40% of the time. So the majority of women require the more advanced therapies. And it's interesting that we have 3 third-line therapies. And those range from things like bladder Botox to sacral neuromodulation, where we stimulate the bladder and function and work on the nerves and really focus on that, to actually a procedure that's very similar to acupuncture called percutaneous tibial nerve stimulation. And we'll go into that in more detail soon, but those are kind of more of the advanced treatments that the majority of patients require because medications are good, but they aren't great. So now also when it comes to urinary retention, I have a very similar patient care pathway, but remember this disease process is slightly different. But again, I start with that initial consultation. Again, it's a fact-finding mission. When you see me for the first time, not only am I developing our patient-doctor relationship, I'm making sure you're comfortable, you feel comfortable disclosing all the information. And again, we're talking about very intimate things, your most private secrets that you're sharing. We're talking about bladder and bowel function or dysfunction. And so again, a lot of that initial visit is just me listening. And again, we go through that behavioral modification. The behavioral modification for urinary retention is slightly different. The medications are different, because with urinary retention, I'm trying to jumpstart the bladder, whereas with the overactive bladder, I'm trying to suppress the bladder. So it really kind of depends on what's going on. And some of the same advanced therapies are really great at managing urinary retention, one being sacral neuromodulation. So the great thing about sacral neuromodulation is that it's great for patients who have overactive bladder, but it also is good for the patients that have underactive bladder, because it's common that you can have two sides of that coin that interplay at any given moment. And so it's nice that I can cover both with one therapy. And then lastly, fecal incontinence. So a good number of patients will have both urinary and fecal. And the reason why I say that is because it all stems from the same signal, the third sacral nerve, that has two branches, that branches anteriorly up to the top for the bladder and posterior down to the bottom for the bowel. And so if you have dysfunction in one area, it's highly likely that you may have dysfunction in the other. Again, with that consultation, I'm gaining that information of how frequent is this happening to you. For fecal incontinence and bowel function, I focus a lot on your diet. I focus a lot on hydration. I focus a lot on your activity level, because really there is a strong link between what you empty based on what you ingest. And so I talk a lot about, is there foods that trigger you? Do you have diet intolerances, like things like dairy, things like gluten? And we really go into diet changes. I do have a dietitian in my office. Her name's Elle. She's lovely. She's one of only 2 dietitians in the country that specialize in both bladder and bowel dysfunction. And so I will have you meet with her as well, just so we can optimize that initial treatments. We might very well need to move on to advanced treatments, but we want to optimize the initial treatments because they will only serve you well, for the rest of your life in that way. Again, I believe in short-term follow-up. So I'll see you back in about 4 weeks. Sometimes we stretch it out to 6 to really see if our interventions are helping you. If they aren't, we start again, we reevaluate, and we can move on to some of those advanced treatments. Now, the advanced treatments for fecal incontinence include sacral neuromodulation as well, but there's also some surgical options where I can repair the muscles and do other procedures like that as needed. Also, when it comes to fecal incontinence, I work very closely with my colorectal colleagues as well as my gastroenterologists or GI doctors to make sure there's nothing else going on and that all the appropriate testing is performed. So I can truly help you in that way. So the initial treatments for overactive bladder, just in more detail, because I am a quick talker, as I'm sure you've determined. So I start first with the behavioral modifications. And this is everything. This is that foundation. And so I mentioned, lifestyle things. I talk about what's normal fluid intake. So for most individuals, they should drink about 42 to 64 ounces of total fluid per day. The majority of that should be water, not Diet Coke, not coffee, because they're not as hydrating as water. And so I discuss limiting very well-known bladder irritants like coffee, tea, carbonated water, alcohol. And I joke, all the fun things, but I'm very strict in the beginning to see how great can we get you? Can we get all of your symptoms to resolve with these small measures? Because then at least we know we can cure, and then we go from there. There's also bladder training exercises, because there's an intimate relationship between your pelvic floor and your bladder, pelvic floor being the pelvic muscles that support and hold everything up. And so I might recommend that my patients work with a pelvic floor physical therapist, so they have in-person monitored exercises that are tailored to them. Other women are perfectly fine doing exercises home, and I have them check in, and they do kind of what I jokingly call an independent study and work on that way. And then we have 2 classes of medications. So we have the more historic legacy medications that are called anticholinergics, and those are on the bottom right of your screen. And what those do is they relax the bladder muscle, and they get rid of that hypercontractivity, that bladder spasm, but they do have some negative side effects. One being that greater than 3 years of use for some of them can result in memory issues and memory loss. And so a lot of providers like myself are really limiting our use of what's called anticholinergics, especially in patients over 65, because most of us need no help to forget things. And so I don't want to encourage that. The class of medications I use most often are on the lower left. Those are called the beta-3 adrenergic medicine or beta-3 agonists. And there's 2 of those now on the market. And those are actually more effective than anticholinergics. They're newer, so they tend to be more expensive, which is why some of my patients it's difficult to afford their medications. There can be up to $300 a month, depending on their drug coverage or their prescription coverage. However, they don't cross into the brain. They don't result in memory loss, so they're safer in that way. And they also aren't as drying. So now we talked about kind of the basic therapies. Those are first line, the behavioral modifications, the pelvic exercises. We talked about the medications, that's second line. And then now we're taking a step up to the advanced treatments, which are the third line treatments, and just kind of moving our way down that algorithm. So now the procedure that reminds me the most of acupuncture is called PTNS, or percutaneous tibial nerve stimulation. And so what I do is I tap in a very thin acupuncture needle near the bone in your heel. It's called the medial malleolus. And so that's what this is trying to show here. It's kind of the inner side of the foot. And what that needle does is it activates the tibial nerve that leads to bladder control. And so it's connected to a little machine that generates energy. And so whenever nerves communicate, they all communicate through energy. And so all of these involve kind of a wire and a battery. And so that's what the PTNS does. It's a highly effective treatment, but it does require a lot of travel. It requires 12 in-person weekly sessions, and they last about 30 minutes each. And typically the response can, here it says around 5 to 6 sessions. Sometimes you can see it as early as 4, but we do still continue for the 12 weekly sessions and kind of go from there. Now, when it comes to long-term maintenance, it can be tricky. I will have patients come in monthly and then quarterly thereafter. The next treatment is called bladder Botox. And so what Botox is it's a toxin. You inject it into muscle and it paralyzes muscle. And so whether it's the forehead to get rid of those wrinkle lines or the jaw lines to get rid of headaches, wherever you put it, it will relax muscle. And so there's, an FDA approved way to use it where you inject it into the bladder in this grid-like fashion. And so that's why you see those dots like that. And what it does is it relaxes the bladder muscle to get rid of that spasm. Okay. Good news is it's covered by insurance. So there's commonly not a high out-of-pocket deductible. Bad news is it tends to only last about 6 to 9 months. And so I joke it's like going to the dentist. You need a plan to come in every 6 months to have the Botox treatment, or the condition will return and the urine leakage will return. There is also a risk of developing tolerance. The body, whenever it interacts with a substance again and again, it can develop what's called antibodies. And so the Botox efficacy or its success can decrease over time. And then now on to what's called sacral neuromodulation. And so what this is it's essentially a bladder stimulator. It's a device that helps regulate the signals between the bladder, the nerves, and the brain. So remember how the original slide I spoke about normal bladder function really requires 3 things: the brain, nerves or wiring, and the bladder. And their communication lines, it needs to be free, right? It's like a freeway that has no traffic. So the signals need to move both northbound and southbound without problems. And so that's what sacral neuromodulation helps to do. And so in this image, what you can see is the battery, which is a small battery here. It's about the size of a small flash drive, and then a wire. And that wire actually communicates with this kind of little yellow string here, which is the 3rd sacral nerve that helps to control both the bladder and the bowels. The beauty of this treatment is there's a trial period. So unlike many of the procedures I do, essentially any other procedure I do, there's a trial period. So it's a try it out before you buy it. I know based on data, based on studies, that it's a highly efficacious procedure. However, let's see how it works in you. And so what I do is I commonly do my trials in the office, where I have you come to the office, I have you lay on your belly, I numb 2 little areas in your lower back, and I place 2 wires. You leave my office with the 2 wires secured to your back with a Band-Aid and a belt around your waist. Around that belt is an external battery that helps to control it. Because again, for the device to work, you need a wire and a battery. I have you trial it for 3 to 5 days. And our goal is to notice greater than a 50% response in the signals. And if and when we do, that lets me know that this therapy works for you. Okay. And I kind of jumped ahead a little bit because I get really excited about certain therapies, but in detail, the next few slides will go into that into a little more detail. So sacral neuromodulation, like I said, is a device that has 2 parts, a wire and a battery. And there's two manufacturers for this device. And the one that we're going to talk about in detail is made from Axonics. So let's continue into Axonics therapy. So now, what is Axonics therapy and what is called sacral neuromodulation? And so what it is it's a treatment that's indicated in 3 different areas: for overactive bladder, for urinary retention, and for fecal incontinence. So, that overactive bladder, that I gotta go right now. Urinary retention or underactive bladder, I can't go when I need to. And then fecal leakage, which is just that accidental soiling of stool, either associated with urgency or just passively on your undergarments. And so now again, how does that therapy work? So it works by restoring that normal communication between the bladder and the brain. So again, it's that highway with the north and south directions are clear. And so it's restoring that normal communications. And so then kind of what's the first step? So the first step is that office trial, okay? And for the majority of my patients, I'll do it in the office. There are some that I will trial them in the OR, in the operating room, so it will require 2 trips. For the majority of patients, we can do the trial in the office. And so what you see in that lower right-hand corner of your screen is all that's involved in the trial. So the green piece right here that looks like a key fob, that's the remote. And so that can turn the device up, down, on, off, okay? And then the actual stimulator is this battery here, and this is what would be in the black belt that would go around your waist, and the actual wire is this lead here, and that's what communicates with the 3rd sacral nerve. And now when it comes to how big the battery is, remember how I mentioned that it's like a narrow thumb drive? Look at it in relation to a quarter. So it's about the width of a quarter, slightly longer. And to place it, I actually make an incision that's 2 centimeters. This is the final battery when everything is placed. This is not the trial. 2 centimeters is about 1 inch, so very small. And through battery science and through a whole lot of engineering, it's able to safely deliver the therapy in a very compact footprint that can last anywhere from 15 to 20 years. And can be done first step in an office-based procedure and second step as an outpatient procedure, meaning you go home the same day. So now historically, sacral neuromodulation entered the marketplace in 1996. And initially it had a major limitation, really up to, I would say 2019, late 2019, it had a major limitation, and that was you couldn't get a full body MRI. And as we all know, there's some conditions where you need an MRI. You have knee pain, shoulder pain, back pain. We like to get MRIs. You have a condition like multiple sclerosis or a stroke, you need to get MRIs. And so the nice thing now is through evolution of just science and scientific advancements, this is now therapy without limits. So you can get an MRI, you can get any imaging that your doctor sees fit, and all we do is turn the device off. There's no longer that limit. And so again, we talked about, or I mentioned, the patient remote control. It's very, very easy, doesn't require charging or being plugged in, and it's actually mirrored after the VW key fob, where it's very simple to use, an up and down arrow, on and off. And many of my patients, it's kind of a set it and forget it. I'll set the program, they get to benefit from excellent bladder and bowel control, and then they only bring the remote control in when they see me. It's not a fussy treatment. You don't have to fuss with it a lot. Now, there's a charging and non-rechargeable system. When it comes to the patients who have the rechargeable system, we put a little hockey puck on the back, and that's what's shown here in the lower left. And what that does is it charges it. So I tell my patients, charge it once a month, maybe on the first of every month. It'll take about an hour or less. It's wireless, so you can charge it at home. You can be, running errands, within your house, or doing dishes, making a meal. You can also be watching your favorite TV show and charging. It's unlike the bladder stimulators that require, the spinal stimulators rather, that require daily charging. This could be once a month charging, which is beautiful. And there's also a non-rechargeable option where you don't even have to charge. And so initially, when the rechargeable option was available and when it came to the market, I myself was skeptical. Are my patients going to be able to figure this out? Are people going to are they going to forget to charge? Is it going to be difficult? No, I was wrong. You know, at the end of the day, sometimes your patients will surprise you, people will surprise you. And this is the result of a study where they looked at it, you know, how easy is it to charge? 94% of people say charging frequency and duration is acceptable. And 98%, they actually don't charge as often. You know, they charge weekly to monthly, and you really kind of can determine your frequency of charging depending on the level of stimulation and how much battery juice you're using to provide that excellent bladder and bowel function. So more patient testimonials. This is Donna, who's a 71-year-old. She says charging is as easy as anything. And again, what you know doesn't charge, right? Cell phones charge, we're used to charging everything. I have my computer plugged in now, all of those things. And so she says she can sit there and watch a program or read a book and charge and make sure she's doing things to help both her bladder and her bowel function. Now, the other thing is how durable is this therapy? And 93% of patients achieved meaningful, long-lasting improvements that were clinically significant, meaning that you noticed the difference and it lasted 2 years or more. You know, we have data stretching all the way out to 7 years. You know, in science, we don't tend to have clinical data out 7 years just because people stop answering your phone calls. You know, there's a lot of loss to follow-up to track down all your study participants after 7 years, but there's actually excellent data looking at sacral neuromodulation, showing that it's safe, it's efficacious, easy to use, and it's that great option for you. And so again, this is looking at 2 years after implant, over 90% of patients were satisfied with the results. You know, 94% satisfied, and 93% would undergo the therapy again if they had the same expected results. And so now this is Jill, who's 45. So urinary incontinence and fecal incontinence can impact you at any age. Fecal incontinence in general can start in your 30s and your 40s. And so this is just, you know, the quote for another patient. It's just so fantastic to live a normal life. The implant procedure was much easier than what I had thought. So now that's kind of the overactive bladder treatment. Now we're moving on to stress urinary incontinence, which again is that leakage with sneeze, exercise, laugh, cough, walk. Some of my patients will leak just rolling over in bed, standing from a chair, because it's whatever increases the pressure on that urethra, which is the bladder opening, could then cause a leak. And so again, let's start a little bit about normal bladder function, just to remind you for any of the late joiners. So the bladder really has two functions. It needs to store and it needs to empty. Now for the bladder to store urine, the bladder itself needs to relax, and that urethra, which is this kind of bottom part here, needs to close. So it's as if that door needs to close and it needs to be closed tight. And then for you to empty, the bladder contracts, the door opens, and that's how you expel urine. So then what's going on with stress incontinence? And so for a normal urethra, it has a muscle band that keeps it closed, and that where you have control to keep it closed. However, if those muscles weaken, both outside of the urethra and within the urethra, there's muscles, then you suddenly cough, you sneeze, then you leak. And for some women, it's just a couple drops, other, it's a complete flood. And it really just depends on how much urine is in the bladder and how strong that force was. But again, no, you're not alone. Your quality of life matters, and we can do things to help. So when it comes to stress incontinence, it's one of the most common conditions impacting women. 1 in 3 will suffer from stress incontinence at some point in their life. And then 60% of all women say their symptoms severely impact their quality of life. And it can do that in 4 different areas. Your mental health, it can lead to self-esteem issues, anxiety, depression. Your physical health, you can have skin breakdown, meaning that area is just always wet, infections. And like I said, it's one of the #1 reasons why both men and women are committed to nursing homes. You can lose your freedom over this. It definitely can decrease your productivity by interrupting your work, interrupting your family, your intimacy or intimate relationships. It can impact, and it can have a negative impact economically. Pads, incontinence devices, incontinence supplies are very, very expensive. On average, you can spend over $900 a year on your incontinence products and on laundry. So good news, there's treatments that can help. When it comes to my treatment algorithm for stress urinary incontinence, I kind of joke that it's an equilateral triangle. And you can kind of move from any one of the sides. They're all equal and even. At the top is pelvic floor exercises. Again, those foundational treatments. And the next on the lower left is the urethral bulking. And on the lower right is the surgical sling. And I really feel like you can move within any one of those three. I have women who are like, well, I want to do the least possible. Let's do the exercises. And if they're not happy, then we'll move to the bulking or the sling. I have women who have had a sling and worked great for them. Now they're starting to have leakage again. So I might do the bulking or I might do the exercises just to get them to that level of cure or dry that they desire. And so really that initial visit is kind of that discussion of what treatment is best for you. Where do you want to start in this triangle? And we kind of work our way around as needed. Again, you know, that pelvic floor exercises, urethral bulking, surgical sling. This is just more in a horizontal fashion, but it really is equal and you can move either direction. So now when it comes to pelvic floor exercises, again, these are the lifestyle exercises. This is when you hear a lot about Kegel, and that's named after Dr. Kegel, where it's a contraction of your pelvic muscles that can help strengthen the muscles surrounding the urethra. And you can do that with or without a pelvic floor physical therapist. Then we have kind of the gold standard, which is called the surgical sling or the midurethral sling. That does involve mesh. Mesh is a plastic-based material that's designed to kind of cradle the urethra and provide support. It has a very high success rate, although the success can wean over time. However, it is associated with at least a 3% mesh complication rate, where that mesh can kind of poke its way through the vagina, result in a mesh erosion, bleeding, and pain. And so many patients would like to avoid mesh use if at all possible. And so we have those discussions. I also have some women who say, you know, I want one treatment, I want the most efficacious, let's go for the sling. I understand the risks, and that's what we do as well. So again, it's the best treatment that fits you and your needs. And then third, it's called urethral bulking, or what I call transurethral bulking. And this is, again, focusing on the urethra itself. The other two treatments focus on the muscles that are trying to give the urethra support or actually literally hold it up, and kind of a hammock analogy. But transurethral bulking is what actually works within the urethra, within what's called the sphincter or those muscles, to provide additional support. And in this procedure, a material is injected called Bulkamid. It's a water-based gel that helps bulk up that area to provide that support. It's a low-risk procedure, and I perform it in the office. Actually, since May of 2020, so not quite a year, May of 2021 rather, I've done over 200 of these treatments. And the majority, probably 190, have been in the office. And so it's a very well-tolerated procedure with very good results. And the beauty of it is you can drive yourself to and from. You don't have to starve like you do for surgery. And it really allows you to do something for yourself and to achieve that goal and achieve that freedom of having urinary continence and being dry. And so a little more about Bulkamid. I mentioned the water-based gel, but I didn't really talk about it in detail. So we're going to go into detail into that treatment. And so what is Bulkamid? So Bulkamid is a minimally invasive, non-mesh alternative to stress urinary incontinence or urine leakage with cough, laugh, sneeze. And it involves a gel, which is water-based, that helps to cure the leakage, again, with cough, laugh, sneeze, or stress incontinence. And I've actually put it on my finger, and it really reminds me of hair gel. It's about that consistency where it's soft and moldable, very natural in that space. And the body, because it has a high component of water, knows what to do with it. It doesn't calcify, it doesn't turn hard like some of our other traditional bulking agents. It's very pliable and very natural and dynamic in that way, which is the way the urethra is meant to function and be. So I'm going to start this video. It's going to kick us out a little bit, but that's okay.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
And anyone I see in my office, that's the video I show in my office. So I will talk about Bulkamid. I will show you how I do the injections, but then I will also have you watch a video just to make sure you get all the information you need from A to Z about this therapy. And so that'll be a video you'll see in the office, a little more to come. And so now again, how does Bulkamid work? So remember, the problem is that the urethra is just too open. It's a little too gapey, right? It's like that old window that leaks air. And so really what the Bulkamid does is it's that weather stripping. And so it helps to bulk up the area to provide support to shut that door or to shut that window. And it does that by creating these 4 little cushions or 4 pillows that help to narrow that opening. Now, it narrows that opening when the bladder is full. But when it comes time to empty, your body will relax, everything will open, you'll be able to empty just fine. But it's really focused on when you don't want to empty, when you're trying to stay dry, to make sure that that door is closed. Now, I do inject in 4 areas. I always use my hand analogy as if this was the face of a clock, and I inject at 7, 5, 2, and 10. And that's what kind of this correlates to, 7, 5, 2, and 10 to really provide that support. So now what do you need to know about Bulkamid? So it's safe and effective. 92% of women report being cured or having significant improvement following Bulkamid. It's a simple procedure. I commonly do it in the office. I also will book some women in the OR, but the majority I can do it in the office. And it is a relatively quick procedure. It does say 10 to 15 minutes because I numb for 10 minutes. And so I inject lidocaine into the urethra. And usually there's no needle. I just kind of put it right there and it gets absorbed so the procedure is comfortable. And then it's a long-lasting, durable benefit. This is a one and done treatment. The majority of my patients don't even require a second treatment. Some do, but the majority don't. And it can last forever, ideally. We do have 7-year data that shows that it is durable and that the symptom-free status you have now, you'll have in 7 years, you'll have thereafter. So now all of you ready for relief? So getting started. So the way that you get started is, you're going to determine, I'm sure while you were listening to this, you were thinking, oh, that's me. I have this symptom. I have that symptom. Would this treatment work for me? And so the first thing that I want you to do is to schedule a consultation. Come in and see me. I'm happy to see you. I'm happy to, again, do that fact-finding mission where I hear about what are your goals? What are your treatments? What you want to be able to do and what limits you need to overcome to achieve those goals. I have women who say, I want to attend my grandson's graduation and I don't want to have to sit at the end of the aisle. I want to sit in the middle. I want to sit in the center. I want to be present. I want to be able to visit my grandchildren. I want to be able to get on a plane. I'm tired of sitting out the jumping jacks at the exercise class. I want to run. I don't want to be the butt of my 10-year-old's jokes that they want to make me laugh so I pee my pants. It's whatever your goal is, we can work together to help achieve that. I can't guarantee cure for everyone, but my goal is always the gain. This is where you are today. Where can I get you tomorrow? Where can we go from there? And then when it comes to different therapies, we do what's called a trial. And then I see you back in a short duration and we kind of go from there. And so the next step is you schedule an appointment and I see you in person in my Dedham office. I also have an office on the Cape, my Hyannis office, that I'm there every Tuesday. And I just want to thank you all for tuning in. This has been great. Spending this last hour or so, 46 minutes or so with you on this Monday. And I'll open it up for any questions. Let me stop this share here so I can kind of see y'all.
Dr. Johnson, I think I want to start with our question we get a lot of while we're waiting for patients to type in here. And that is, how long does it typically take for patients to get symptom relief, both on the axonic side and the Bulkamid side?
So the axonic side, usually the trial lasts about 3 to 5 days. So some patients, they will notice immediate symptom relief from axonics. So literally that very evening during that trial, they notice relief. I've had people call me the next day and be like, okay, I've already passed. I slept through the night. When can I get this done? They're the patients who don't want the trial to end because they don't want to go back to their symptoms as we await the implants. So it really can be immediate, but on average about 3 days to have symptom relief. With Bulkamid, it's immediate. So I will do the procedure. I then have you go and empty your bladder. And as long as you can empty well, then you go home. And so for many of my patients will notice immediate benefit from the Bulkamid. Some patients, it might take 24 hours if their bladder got a little irritated just from the procedure. You know, there is a thin little scope that goes in, but usually it's immediate.
We had a question come through revolving, basically been taking pelvic floor therapy since October and looking to see what should be their next step.
Oh yeah, so if you're running on pelvic floor PT and you haven't experienced enough benefit, meaning that you're still having symptoms, then come in and see me or come in and see your doctor, and we'll discuss what's going on and discuss the next steps, because pelvic floor physical therapy isn't your only option. But I do need to clarify what treatments you've tried, what's worked for you, what haven't. Some medications are contraindicated in certain patients, meaning I can't use them because there might be other medical conditions you have or allergies you have. And so it can be kind of complex what the next step is, but start by coming in and seeing your doctor, whoever sent you to pelvic PT. And so we can manage from there forward. You can have multiple stomach surgeries that can make things less efficacious, meaning that PT may not help you as much, depending on your ability to really engage your core and engage your abdominal muscles. But the different procedures are still equally as efficacious, meaning that they're going to work at that same 90%, regardless of your prior surgical history and what surgeries you've had.
Dr. Johnson, we had a question come through about weight limitations for certain treatment options that you discussed. Can you kind of go through that?
Yeah, so there really isn't weight limitations. There was a study, however, let me back up a bit, that showed that if you lost 10% of your body weight, that your urinary symptoms can improve by 50%. And so there are times where if a patient of mine reports a recent weight gain, especially during the pandemic, I might mention, okay, let's try to stabilize your weight and or lose weight because you may not need any further treatment. But there is no weight limitations for both the Exonics, for really any of the treatments. You know, I would say the only limitation would be the PTNS. If someone has ankle swelling, then I wouldn't use that therapy. That's not the best therapy for them. But when it comes to bulking and the sacral neuromodulation, there's no weight limitation, no.
Dr. Johnson, we get a lot of questions revolving around limitations past procedure, both on Exonics and Bulkamid. Can you kind of walk through what your recommendation is for patients as they're during the trial and even after the implant, and then after the Bulkamid, can they resume normal activity? What's that look like?
Sure. So, so you absolutely can resume normal activity a lot sooner after these two therapies than you can after traditional surgery. So when it comes to Bulkamid, the only limitation post-procedure is no intercourse for 24 hours. But other than that, you can go back. I've had patients go back to work. I've had employees go back to work. I've had people go golfing later that afternoon that had Bulkamid in the morning, and they do just fine because it's not going to interact with their urethra, you know, their different activities. It's just intercourse is a limitation for 24 hours because it can put pressure on that area. And that gel, that water-based gel of Bulkamid is moldable and sculptable for anywhere from 3 to 4 weeks after placement. Now, when it comes to Exonics limitation activity, you do have a 2-centimeter incision that has stitches. And so I just don't want you to tear your stitches. So I say, you know, no excessive bending or excessive lifting. You know, it's not the time to go to the gym initially after that procedure. You know, let the sutures dissolve. And so usually my patients will give it a week or two after, just to make sure that incision is closed and just so they don't pop stitches. But there's not a long limitation. It's not like, you know, prolapse surgery or other procedures where you're out of commission for weeks on end. No.
Excellent. Looks like we just received another question through the chat.
I'm 66 years old. All of a sudden, I can no longer hold my pee on occasion. Is this the beginning of something serious, or is this temporary? This isn't often, but emergent at times, especially traveling. So it's hard to say. I wouldn't say it's serious. It's something bothersome. So all of the conditions I described today are quality of life conditions. They're not quantity of life conditions. So so the symptoms don't bother you. You don't have to treat them because they're not going to kill you. They're not a sign of something dangerous, but they're annoying. They limit your happiness. They limit your activities. They limit your joy in that way, or they can. So what I would ask yourself is there something unique that you're doing when you're traveling that you don't do at home? Maybe you're engaging in more bladder irritants than normal, and that's what's causing these sudden episodes. Because what those episodes can be or might be are bladder spasms. And so if you've had more caffeine or more, alcohol or more, seltzer than you usually do, then that can trigger some of those spasms. There's also other changes in your pelvis that can happen that can irritate the bladder and lead to leakage. So it can be kind of a complex onion, I could say, where there's many layers. But I would start with looking back at the basics, which are the bladder irritants. Avoid the coffee, tea, carbonation. Maybe you have a soda when you travel and that's too much for your bladder. And focus on limiting those, having plain water, not even with bubbles, because that's the best thing for the bladder.
Excellent. Dr. Johnson, at this time, I'm not seeing any other questions coming through on the chat. So we'll flip it to you for closing thoughts and close us up.
Yeah, so I would just say in general, I did mention that overactive bladder, stress incontinence, fecal incontinence are not quantity of life issues. They're not dangerous, but that does not make them unimportant because they are quality of life issues and no one can drive your quality of life like you. So it's very important that if you're suffering from any one of the conditions that I described tonight, that you seek care, whether it's you come into my office. I'm happy to see you in Dedham. I'm also happy to see you in Hyannis or on the Cape, or you see another provider. There are numerous of us all over the area that can help you and to really help improve your joy, your passion, and your quality of life. So that's kind of what I would say as a wrap up. So I'm so glad you guys tuned in. I do see one last question. Yes. Will PT help with fecal problems? Absolutely. So pelvic or physical therapy is first line options for any condition impacting your pelvic health because your pelvic muscles are closely related to your bladder and bowel function. And so for patients who have fecal leakage or accidents of stool, liquid, mucus, physical therapy, especially working with the PT, can absolutely help because they can help your ability to squeeze and even sense what's going on the rectal side. So absolutely, PT can help.
Excellent. Yeah, I'm glad you caught that. That one just popped through. All right. Well, thank you, Dr. Johnson. Thank you for the patients that joined us this evening. I'm going to go ahead and end the poll and end the webinar. Thank you guys again for your time.
All righty. Thank you all.
All right. Thank you, Dr. Johnson. Bye-bye.
Bye.